Hey, I'm Shrenik, founder of Sunrise Health. Behind me is my co-founder Ravi, and we're both working to make smarter psychotherapy a reality. Now, mental health conditions are a massive social and economic issue. It's estimated that 1 in 5 of all Americans have a mental health condition, and 2 in 3 of those diagnosed get zero care whatsoever. Now, some populations have this worse than others. More police officers and firefighters actually die from suicides than from the physical wounds that they receive on calls. But it takes another example for us to realize that you can't solve this problem just by throwing money at it. Many of you have probably heard the statistic that 20 veterans take their own lives daily. But most people don't know that the VA actually stretches itself to spend over $8 billion a year on therapists and other care resources that don't reach those who need it the most. The majority of veterans who are dead by suicide last year weren't in any form of VA care. We at Sunrise Health attacked this issue through a mobile app for text-based group psychotherapy powered by natural language processing. This allows us to broaden access to care to patients, but also gives today's overburdened providers a means to scale to the true magnitude of this issue. Our team's experiences run the full gamut of healthcare and AI, from actually witnessing these conditions firsthand as first responders, to building multiple AI products within startups and multinational corporations, to working with thought leaders and medical experts in psychiatry from Johns Hopkins. Now that you know who we are, let's jump straight into the demo. Here you can see Ravi signing into Sunrise as a user. Users join groups anonymously, which greatly reduces their fear of stigma and judgment when sharing. Groups consist of 5 to 7 users and are moderated by a therapist. Once a user has been accepted into a group by the therapist, he can text his peer support network at any time from anywhere, while also participating in more scheduled therapy sessions via VoIP conference calling. What we do here is marry the persistence of peer support with the demonstrated clinical efficacy of therapy. Of course, it's impossible to expect any therapist to read every single message generated on our app, and that's why we designed advanced NLP algorithms to run on user messages and detect messages containing suicidality or maliciousness that require immediate provider intervention. Let's jump straight into this technology, visualized on our moderator dashboard above. Now, most text messages sent by users don't require any kind of intervention, and they're visualized as green data points on the graph that you see, whereas content that's red represents messages that require provider supervision. Now, we catch the easy things like "I want to kill myself," but the true nuance in what we do is evident in a sentence like this: "I want to walk out into a lake and watch as the ripples go out as I go under." No negative words, but we can understand the latent suicidal ideation that's implied by a sentence like this. What's more, we can flag a response like "sounds cool to me," which is negative only because of this conversational context. And what these tools do is they increase the efficiency of today's providers by allowing them to focus their time and energy on the users who need help exactly when they need that help. That translates to a greater patient capacity and a reduced cost of care itself. It also means that we can detect complications early and reduce the number of crisis incidences within a population, while improving their general health and wellness and giving an institution insights into the true needs of its population. All right, back to the slides. So because of these gains that we offer at scale, we deploy with the B2B SaaS enterprise model, where we license out this technology to organizations that already have an infrastructure of providers to make them more efficient. By working with these established providers and getting revenue directly from an institution, we can stay lean as a tech company and provide services to the end user at no charge to them. What we're doing at Sunrise is leaps and bounds over the existing solutions for mental health care, which I'm going to visualize for you here with 2 parameters. One is accessibility, which is a combination of ease of use and cost of care. The other is toxicity, which I'm going to talk a bit more about soon. So first, you have traditional face-to-face therapy. It's been the clinical standards for decades, but it's expensive, hard to access, and really hard to retain patients in. To solve this, we saw startups that let you text a therapist from your phone, like Talkspace, emerge, but their one patient to one provider model isn't scalable, and this prices the majority of people out of reach of these solutions. So hundreds of thousands of people have no option except anonymous social media sites like Reddit and Yik Yak, where the security that they find online has them forming impromptu support groups to discuss what's actually on their mind. But this freedom comes at a cost: toxicity. And the trolling that we're all familiar with online manifests itself here as users literally telling others with depression to go ahead with killing themselves. At Sunrise, we combine the best parts of all of these solutions by deploying the relatability of groups in an environment kept safe through technology. Our early adopters include fire departments, universities, and police departments, organizations with insular and stigmatized cultures that benefit from an app like ours. After validating out our model here, we'll scale to a market worth over $1.5 billion, including larger healthcare systems, the federal government, and an API service for our NLP tools. Currently, we're live at multiple pilot sites, several of which are funded by the National Institute of Health and Johns Hopkins, with the aim of developing population-specific language modeling tools. Once we finish these pilots, we can hit the ground running, since we already have $4.5 million in commitments from major metropolitan governments and national healthcare systems. We're scaling as we speak, so if you want to join this list, contact us at sunrisehealth/disrupt and bring your mental health care infrastructure into the 21st century. Thank you, and we're excited to take your questions.
How do you deal with false positives? In other words, we've all had Siri say inappropriate things back to us, right? And whereas your NLP is never going to be perfect, but when somebody is on the edge of anxiety and depression, if the wrong thing is said to them, it could have very horrendous consequences. So how do you mitigate some of those risks in your model?
So that's like a two-part question. The first part is how do we mitigate the risk, right? So one thing is we allow users to flag other users' content. So if Shrenik is having a bad day, I can flag that content, and if the therapist agrees with it, it becomes a new data point for us. And because we've implemented online learning algorithms, our algorithm will not make the same mistake again. The second thing is therapists can also flag content which goes through the same process. Now, about someone saying something inappropriate to a user, it's only users communicating with other users, and we have a rigorous onboarding process where they understand what the tenets of the platform are, what anonymity is, and how they should interact with each other.
Do you put people into groups, or is this one large community?
No, it's all groups. So one of our key insights is that to develop these bonds, shared community and culture is extremely important. So what we do is we have a triaging process. So when a user tries to join a particular group, the therapist triages them. We have standardized diagnostic forms to figure out whether this user is a good fit for this group or he needs to be referred somewhere else. Then there's an onboarding process to help that user become part of that community and culture.
So what have you learned about women? So my friend Rachel Simmons is writing a book about how right now on college campuses there's a huge mental health crisis with the suicide rates of young women being much higher than young men. So what do you think?
Yeah, so specifically we've actually launched at 2 university campuses and done closed pilots there, and we've cooperated very specifically actually with different sexual assault response units on campus that provide that kind of peer support and counseling. What we found with women in particular is that they benefit a lot from a platform like this because that social stigma, that pressure, is particularly present for young women. The other thing that we found is, while a lot of people expect depression in young women, we've also seen anecdotally through our work a lot of anxiety as well. So that's a really common thing that we've seen, and we've basically placed people in groups with providers that specialize in anxiety to make sure that women have that kind of more specialized support.
So how many women are on your team?
So our chief medical officer, Dr. Geeta Jariam, is a woman. One of our front-end designers is also a woman. So I'd say we're at about 4.
So what at the end of the day are you measuring? Are you trying to actually measure therapeutic efficacy, or is it really more of a support group? So if Talkspace is saying, hey, I actually want to measure whether or not somebody's outcomes are better, what are you actually measuring? How do I know how to measure you?
So we focus on measuring 3 things at each site. Now, the first thing that we really try to aim is by combining this peer support group with these therapeutic elements, we try to increase retention and care, because most people actually drop out of therapy in just 2 sessions, whereas your average course of therapy is like 10 to 15 sessions. So we just track the retention and engagement on the platform, and already we're seeing that our users spend an average of 2 messages a day on our platform, which is crazy compared to anything other digital clinical intervention you've seen. Second thing we measure is, of course, just patient outcomes using standardized diagnostic forms, which, like Ravi mentioned, are already integrated into our platform, so we can track their outcomes right like you would in any standard face-to-face care and use any assessment. The final thing that we track is actually the efficiency of the providers. So with our platform, you can have one provider with the aid of our NLP tools and the peer support dynamics actually caring for 30 or 40 patients, which you really can't do otherwise.
And are you doing anything as it relates to screening the providers of the are you doing anything with respect to screening the providers or the moderators?
Yes.
Or is that all done by the end customer?
So two parts to that. It is generally done by the organization because they already have infrastructure and we bring that infrastructure onto our platform. But what is most interesting is we are working with case management organizations to look at providers and figure out through this data-driven approach what is working, why certain providers are better than others. And using this data-driven approach, we can now do incentivization to figure out how to personalize therapy for each individual user.
Do you look at yourself as a corollary to like an Amada Health or a Noom who are utilizing sort of counselors to more efficiently, work with a group of people than having, a private weight counselor or private diabetes counselor?
It's in some parts, yes, but I think what is most critical to understand is the anonymity and on-demand access to care, which is unprecedented in this field, right? Because it's never ever been possible to have anonymous groups be kept safe like that. And you've seen Reddit and YCAT where it becomes toxic. And for the first time, we're trying to keep it safe, and that allows the peer support to take over and give those productivity efficiencies that you're talking about.
How do you price
it seems like you found the perfect environment in universities to begin with. But I think, having been in healthcare a long time, I'm a little bit cynical about the question, who pays and why? So it's that you're either increasing revenue, lowering cost, you're definitely not threatening doctors' revenues, right? Because if they think you're making them more efficient, sometimes they think then an institution will need less of them. So all of a sudden that's threatening. So the question is, when you go to the broader market, where it's really many more independent therapists and social workers, psychiatrists across the board, when you think about the who pays and why, so why does an institution pay you in either terms of increasing revenue or cost?
So the main thing I would say is like our early roots are with Kaiser Permanente. So we conducted 150 interviews of providers and patients with them. And then they're still paying for $40,000 of computing for us right now. And we were like speakers at Kaiser Permanente. What they see is that they need to scale mental health resources because people with untreated mental health illnesses cost 2x more if they have cancer, diabetes, or anything else.
No question.
ER visit.
Yeah,
so
absolutely.
The only way to get those people into care, because they're not willing to seek face-to-face therapy, is a mobile platform like this. But then the corollary comes in, because if you have all of these people suddenly coming into care, how are you going to manage them? You're already at the seams of the current infrastructure. You need these natural language processing and peer support networks to be able to scale it. So to answer your question, universities, first responders, it's easier. They have employee assistance program. They put aside money for this. But later on, we want to go to the VA, HMOs, and other organizations like that.
So how do you price today? Is it based on number of patients that are in the organization? Obviously, you're not actually charging for the therapy service itself. Yeah. So how do you price?
So we basically charge with the number of patients in the total patient population, and that's what we charge when we go to universities, first responders, police departments, and the idea behind that is it's in line with what they already pay for EAP services. So that kind of model is very palatable to them. We charge between $1 to $5 per covered user per month based on the kind of features they want.
But in an EAP service, aren't they contracting with a third-party provider who's actually providing the therapist or the moderator? In this case, you're not doing that, right?
We're not, but they already have.
This is a tech platform for them to provide to the employees, and they're going to still interact with a third-party moderator or a therapist that is not contracted by you. So I would think that the pricing would be less than what an EAP would get who's actually providing the service.
Oh no, yeah, it is less in terms of the dollar that they're paying per person. I'm saying the pricing model in terms of how it's calculated is with the potential population size. And then of course when we go to healthcare systems where it's a bit harder to estimate what their total patient volume is, we would charge per provider on the platform.
So you don't vet the therapist, you don't play any role.
Yes, because therapists are very tailored to the organization. So there are specific therapists for police officers and very different therapists for university students. So it's best generally to integrate with them.
Right. Have you studied the crisis hotline? Sorry.
Crisis text line?
Yes.
So he's a volunteer and we know the founder extremely well and they are used for our escalation services.
Yeah, can you talk a little bit more about your backgrounds and your team's backgrounds? And then I'd also love to hear about the NLP layer and what you've built on and how you're continuing to build on it.
Yeah, so I can start. This is an extremely personal project for me. I built this specifically for a close friend of mine who had a history of suicidal ideation and was relapsing into major depression right in front of me. And even in therapy, the isolation and loneliness between sessions was crippling her. So I built her this. And my background is in natural language processing. I've built artificial intelligence products for venture-backed healthcare startups. And in the United Kingdom, I work for a multinational robotics manufacturer called ST Robotics, where I founded and grew a vertical in the field of natural language processing until it was spun out into its own company and then later acquired. And at Johns Hopkins University, I was researching and working with Shrenik.
So yeah, my background is actually as a first responder myself. I've been a part of multiple rescue squads and fire departments. So I've not only seen how patients, sometimes patients who were classmates from my own high school have died from suicides and overdoses, but I've also seen how responders cope with things like substance abuse and alcoholism and even PTSD, and they refuse to seek care because of the social stigma, even when the resources are put in place, and they suffer as responders because of that. But also, I've also headed the customer acquisition of another B2B SaaS medtech startup where I worked alongside Ravi, and I've researched the economics of healthcare at Johns Hopkins, where I've written papers.
And then for the natural language processing, we tried earlier using like Stanford, IBM Watson. They max out at macro F1 efficiencies of 61. We've currently reached 0.81 in identifying immediate intervention messages, which is unprecedented. And we have good relationships with the director of mental health of IBM Watson, etc. What we've done is we focused on three main things. One is that no model is perfect. So we have this rich ensemble with everything from SVMs to neural networks. Second, we have our own proprietary sentiment-specific word embedding, which is the base foundation for all natural language processing. And last, we focus on computational linguistics to understand context and long-range dependencies, which no one else is doing.
So you mentioned one of your long-term goals was to provide an API for the NLP system. So could something like this be scaled to, for instance, detect and flag abuse on Twitter, for instance?
Yes. And that is something that we've been asked about. There are a lot of forums like Reddit, but specific for like certain populations. So Reach Out is a very good example. It's an Australian one. A lot of people use it for their studies, and we are considering giving them an API service. We've already begun to launch the API service because a lot of case management services, which contract for large insurance company for wraparound services for high-risk individuals, already have their own platform for text-based therapy. So we are integrating with Amada Health.
So you're obviously a lot of your training and focus has been on detecting these particular signals in this particular context. So how flexible is the system?
So that's a really good question because mental health illnesses are all very different, right? What we know is that the manifestations or severe manifestations of all mental health illnesses appear in the same way: suicidality, cutting, harm. So in the most important layer, we have 81% macro efficiencies. Now, as we percolate down, we have to understand the difference between depression for a police officer and anxiety for a college student. And that we are doing with domain adaptation, but those nuances will come as data comes and as users are flagging content so that we can understand more.
Have you analyzed Trump's tweets? That'd be interesting.
What kind of scale do you guys have right now? How big are you?
As a team or as customers?
Both.
So as a team, we have 5 full-time individuals with over 7 contracted people and interns who are participating for the mission. In terms of customers, we already have 30. We are in between pilots, so we have just one running with 30 users from Johns Hopkins, where we are validating out the technology, and we have 3 more planned in the next 2 months. Anne Arundel County, where we are integrating county-wide for substance abuse, Denver Fire Department for the peer support network, and Amada Health for case management.
All right,
So
we are out of time, so give it up for Sunrise Health.